Hi, I'm Dr. Daniel D. Simone. I'm a consultant in infectious disease at the Mayo Clinic in Rochester, Minnesota. I'm an associate professor of medicine, and I am vice chair and senior author of this statement.
Hi, I'm Dr. Larry Bedore. I'm Professor Emeritus of Medicine at Mayo Clinic, Rochester. I had a long-term interest in cardiovascular infections, and I was honored to chair uh, the HA scientific statement that we're going to be discussing today. Today, we're talking about our scientific statement entitled The Update of Cardiovascular Implantable Electronic Device Infections and Their Prevention, Diagnosis, and Management. A statement from the American Heart Association. This was published this year, 2023. Prior version was done in 2010. That was the initial iteration of this document. At that time, for scientific statements, there was an inclusion of recommendations. For the 2023 version, they're not recommendations, but certainly the document is full of suggestions, comments, guidance in the difficult management of these patients with a potentially life-threatening infection of CIED infection. We have a wonderful central illustration with the 2023 version of the statement. For the document, we have three sections: prevention, diagnosis, and management. And we'll start with coverage of prevention. In our statement, we talk about adherence to standard infection prevention measures that are very important in reducing the likelihood of CID infection. It's interesting that we still are advertising the single-dose preoperative cefazolin as part of the prevention package. Actually, back in 2010, that was the only place where we had randomized controlled data to suggest that single-dose cefazolin would reduce CID infection rates. It's still being used. It should be administered approximately 1 hour prior to procedure. And what's different today is the perspective on cefazolin use in the, quote, penicillin allergic patient. The bulk of these patients are not truly penicillin allergic, and there's been a groundswell of activity regarding penicillin allergy and delabeling patients of penicillin allergy history. And so this is a bit of an aside topic, but for the cardiologist, I'm sure those in the EP section have seen some movement in this regard, and I think it's a good thing. Another entity that we get into discussion about in prevention is the antimicrobial envelope. Many of you have heard about this and used them. These envelopes are not inexpensive, and but can reduce generator site infection. And these impregnated envelopes are placed to have the generator placed in these impregnated envelopes. They contain minocycline and rifampin, and it seems to reduce the likelihood of pocket site infection, particularly in the high-risk population. And so that's where we are today with high-risk populations. Use of
I think that's an important point here is defining these high-risk patients, Dr. Bedore. I think that's critical going forward. Is there's multiple scores out there, or multiple scores that are out there that look at defining what are risk factors and what put patients in these high-risk categories who may benefit the most from an intervention like an antibiotic envelope. And that kind of leads into the next section with hematoma prevention. The risk of hematoma increases the risk of cardiac device infection subsequently, approximately as high as 11-fold. So in patients where you suspect a potential high risk of hematoma formation after device placement, something like an antibiotic envelope may be considered. But I think that's something I know we talked to frequently about, who are defining these high risk patients and then individualizing each patient you encounter on would an antibiotic envelope be considered in a patient in that given patient.
Absolutely. And I think we're on a learning curve as far as defining which which patients need this type of product
Mm-hmm.
for prevention. Dan, you want to talk about diagnosis?
Absolutely. It's this part here is very interesting. In other words, how do patients with cardiovascular implantable electronic device infections present? There are several ways they may present, and some are quite obvious and can be on physical exam. You can make that finding with a device that's eroding through the patient's chest at the pocket site generator. The patient may have significant erythema, swelling at the pocket site. And those are quite obvious physical exam findings that can help pinpoint the diagnosis. Where it gets more challenging and where things become very difficult, and I think that's where this statement provides significant benefit to the frontline clinician, are in these difficult cases where the patient has absolutely no physical signs or symptoms of a device infection, and they may just simply present with a bloodstream infection. So they may have fevers, chills, blood cultures are obtained, and they're positive for a specific organism. And as I mentioned, this document will go into the different organisms that you may encounter in these patients who have no physical signs at the pocket site. And then we can discuss what are the tools that are available, what are the diagnostic tools that we can use in a algorithmic approach, as you'll find in this statement, to hopefully guide you down the correct route for these patients. And I think the biggest thing I want to point out here, and Dr. Dora, I'd like to get your thoughts, is in CIED infections, we want to remove devices completely if they're infected. And if they're not infected, we want to keep the device in place. Now that seems pretty straightforward and obvious, but that's the biggest question here. And especially when we get back to those cases where there's no obvious signs of infection, we have to start relying on these diagnostic tests like transesophageal echocardiogram, PET scan, and other findings to try to increase our sensitivity as well as specificity. Because the last thing I want to do is take out a device that was not infected, as that puts the patient at risk for significant morbidity as well as mortality from the procedure itself, significant financial cost burden on the healthcare system. So this is where it gets, I think, is very critical, and this is where the statement, I think, brings a significant advantage as we evaluate these diagnostic tests, and again, provides the frontline clinician with what are the next best steps in order to take, depending on that individual patient's presentation.
Absolutely, Dan, spot on that. If the device is infected, it needs to come out. Why? Because infection relapse rate is high. So we want to remove infected devices. As Dan mentioned, this is complete device removal if at all possible. It's very important. At the same time, we don't want to remove devices that don't need to be removed. So if the device is not infected and yet the patient has some type of bloodstream infection, it's a difficult decision many times. And for the frontline clinicians, I think the requirement is that you have a multi-specialty team managing these very complex patients and making a group decision as to what should be done for these difficult patients. Now, 60+% of the patients with CID infection will have pocket site infection. They will have local findings at the pocket site that are strong findings that indicate that the device should be removed. Those are pretty straightforward. Not all of them, but most of them. But when you're dealing with a bloodstream infection and a negative pocket site, that really requires some scrutiny, more diagnostic procedures than what might be normally required. So yes, we that's one of the reasons why we put this document, this 2023 document together, was that there have been advances in our diagnostic capabilities. They do have limitations, however, and because of the limitations, we have to have a team approach to the management of the individual patient.
Absolutely. And I think that gets into, well, what are these diagnostic tests that are available that we are using in practice, and that the frontline clinician uh, will be faced, hopefully in a team effort with a multidisciplinary team on providing the best care for that patient, as you mentioned. The first one being echocardiogram, transthoracic as well as transesophageal echocardiogram. These are very helpful for detecting valvular vegetation, so infective endocarditis or CIED related infective endocarditis, but also potentially lead vegetation, lead endocarditis. But that gets to a major question or a major potential pitfall is the sensitivity and specificity of an echocardiogram. In other words, can we distinguish a sterile clot that's on the cardiac device lead from an infected vegetation? So that gets to, do we want to get an echocardiogram in every single patient who has a bloodstream infection, regardless of the organism, or does the organism play a significant role, given that there are certain organisms that are much more likely to cause CIED infection compared to other organisms? So I think we delve into this quite deeply into this statement to discuss this issue, because just based on clinical features alone or echocardiographic imaging alone, to be able to distinguish a sterile clot from an infected clot is not possible. It has very low sensitivity and specificity.
I wanted to mention the recent publication of trials, PADIT, PADIT trial. And basically, what it showed was that there was uh, re- no more reduction of CID infection over that of cefazolin when cefazolin plus vancomycin was given with intraoperative acetration wash and then 2 days of cephalexin to follow. That more uh, uh, complex regimen really did not improve outcomes in patients with undergoing CID placement. So cefazolin is still the workhorse and has been very dependable. Uh, it's very interesting also that, as you look at rates of CID infection, what used to be something in the 2 to 3% range, we're probably half of that. And so I think it's been a combination effect, better adherence to preoperative antibiotic prophylaxis and timing of such, better adherence to infection prevention control measures. Those, I think, are key. As with any diagnostic tool, there are limitations. In echocardiography, including transesophageal approach, very important in the diagnostic strategy of CID infection. On occasion, PET-CT, which has become available in recent years, has been useful. There again, there are limitations to the PET-CT. We have good sensitivity of PET-CT for generalized site infection, even when the generalized site is clear of any local findings. Uh, the limitation for PET-CT is that the sensitivity for lead infection is not great. And so, again, looking forward to the future, it is our hope that with nuclear medicine advances, we'll have better tools in defining those patients with lead-related infection.
Yeah, completely agree. And combining those two tests together and select patients and how they may present hopefully increases our sensitivity and specificity of detecting a device infection, and then leading towards our recommendation of complete device removal. So if one part of the device is infected, the entire device we consider the entire device infected. So we don't just do partial removal. It's recommended to do complete device extraction in those where we feel there's confirmation of device infection. And again, you mentioned earlier that the reason for that is the rate of relapse of infection and device retention, or even with partial removal or complete device retention, are significantly high, whereas relapse of infection is quite low with complete device extraction and appropriate antibiotics. And at that point, what do we do with the device? And that's something else we address is just like any infection, we want to know what is the organism, the infecting pathogen, and there's been advances as well over the last decade plus, looking at device sonication, where we use ultrasonic waves to try to break off that biofilm and those organisms off the device, and then increase our yield to detect the organism, as well as broad range PCR testing and next generation sequencing. So these are some things we do touch on in the statement, and as a way for, if your lab has that capabilities or potentially a referral lab, we do provide that for the clinician.
Yeah, I think that's been very important. You know, this sonication procedure was developed here at Mayo Clinic by Robin Patel. It was initially used here for prosthetic joint infection, but it's also been used in other types of device-related infection diagnoses. And so, you know, I don't know if it's standard of care across all the clinical laboratories, but certainly it's part of our diagnostic scheme here.
Yeah, and there are some patients who do not undergo device removal even with an infected device. And I know we talked about this briefly about a recent study in regards to device infection and rates of explantation. Dr. Bedore, do you want to discuss that a little bit further?
Well, you know, it was unexpected, the data described. It was something like 15% of the patients who were thought to have device infection underwent device removal. That was 85% did not. And so, you know, what's happening with these people? How many of them are on chronic antibiotic suppression, which we'll talk about in a moment? And what are the outcomes? That's made us take a relook at this. But I think that if we believe a device is infected, then our position is complete device removal if at all possible.
No. Yeah, that gets into as you mentioned, chronic antibiotic suppression, where the device cannot be removed, or the patient or provider, or the ultimate decision for that patient is that they're too high risk for device removal, and the risk of complications, morbidity, mortality are deemed too high. And we discussed this, that chronic antibiotic suppression, because of the high risk of relapse, it's an option, but typically this should be one of your last options. It shouldn't be the first thing you consider. As again, our recommendation would be our consideration would be complete device removal, but recognizing that may not be feasible in all patients. So in those patients where the risk is deemed too high to undergo extraction, then consideration of chronic antibiotic suppression for as long as that device remains in that patient, they should be on some form of antibiotic suppression based on the infecting pathogen that may be known, or potentially an empiric regimen if the organism remains unknown. So, Dr. Bedore, anything to add to that?
Yeah, Dan, I think you've covered it pretty well here. And I think, you know, we have to keep in mind that about 60% or so, at least 60%, even up to 70, 80% of these cases are staphylococcal in origin as far as infection is concerned. So what we're talking about is some chronic suppressive therapy, which would be an oral therapy for the most part, that would have activity against all these staph. And unfortunately, these staph, MRSA, the so-called MRC, or methicillin-resistant coagulase negative staph, many of those strains will be methicillin resistant. So, you know, your penicillins, your cephalosporins are not going to be options. And but we do have some older antibiotics that still have some activity against these bugs. And it can be difficult to define a suppressive regimen, but for most of the patients, we're able to find something to keep them suppressed. The issue is, you know, is that a better approach than taking the patient earlier on for complete device removal? But we fully recognize that, you know, many of these patients are not going to be or not interested in complete device removal. And so you might go to plan B or plan C. And all of these things are addressed in our 2023 statement.
Yeah, and I think another interesting thing that we do address in this statement is for those patients who do undergo device extraction, we discuss some of the potential options for patients, whether they need reimplantation of a device. So not only do we discuss potential alternatives and some of the latest technology in new devices for these patients, but also important timing and what may be optimal timing for device reimplantation, and also have to consider that there's a portion of these patients, anywhere around a quarter to 1/3 of patients, do not require reimplantation. So it's critical to have the cardiac electrophysiologist closely involved, which is a key member of this multidisciplinary team. That after the device is removed, a good portion of these patients don't need a new device. Now, in the 2/3 of patients that do need a new device, then it's important that the old pocket site has been cleaned, debrided, free of infection. It's placed either contralateral or in an alternative location to decrease the risk of infection to that new device. And then we also delve deeper into timing of reimplantation after infection and devices removed, depending on whether there's infective endocarditis or not. Dr. Bedore, would you like to speak on some of these new cardiac devices
Yeah,
that have been developed over the last decade or so and in use in patients who are particularly at high risk for reinfection?
yeah, I think we have had some advances with these development of devices. Uh, we've, we've used for a number of years now the subcutaneous ICD. Going the subcutaneous route in those patients have had prior, and usually in patients who've had prior CID infection, and particularly if the infection has involved bloodstream infection. So that we've gone the subcutaneous route to avoid that bloodstream infection. These SICDs still become infected, uh, and they have to be removed if they are infected. But at least the likelihood of developing bloodstream infection as a result of the SICD infection is almost unheard of. I'm not going to say it's zero, but it's close to zero.
Well, one of the things I'd like to transition into is discussing some evidence gaps and future considerations where additional research is needed. I think that's a very important part of every statement that comes out is what's needed in research, what's needed to advance not only our knowledge but to provide the best care for our patients. Could you discuss some of the evidence gaps and future considerations that we discussed as a group and our other 9 members of this writing group discussed as where more focus and attention needs to be paid to?
Yeah, I think the percutaneous mechanical aspiration, where that fits into this paradigm, we're not sure yet. It's predominantly been case report, case series that have been describing this procedure. Uh, a patient with a CID infection who has uh, infected clots may not be great surgical candidates, are refractory to antibiotic, appropriate antibiotic administration, still suffering from sepsis, still suffering from bloodstream infection. This might be an option. It's just too early to know, But that's one of the future uh, potential interventions that are of our interest, and certainly the procedure itself seems to be escalating as far as the rate of the procedure. But right now, I think it's still a bit a question mark. Um, there's a leadless pacemaker that's available that here again in the studies to date, the likelihood of the leadless pacemaker becoming affected, particularly by bloodstream infection, is very, very low. I think there's only been a few or limited number of cases in patients where uh, you know they've had prior history of CID infection. They're at high risk for subsequent episodes of CID infection. They require a device. The leadless pacemaker may be an option for them, but certainly to be evaluated by the EP folks to make that determination. Dan, any other advances we need to address here?
Yeah, I think advances in nuclear medicine. So
Mhm.
we touched on PET CT a little while ago. For the most part, they're using 18 FDG or as a marker or isotope. Potentially looking at more bacterial specific. So if I know this patient has Staph aureus in the blood and I'm suspecting Staph aureus as the cause of the device infection, potentially having specific isotopes or markers that will better adhere to the bacteria rather than just looking for a specific, rather than just glucose uptake and looking for where that tag has been taken up. I think that has, I think that's starting to take off. There's a lot of research interest in this. And with time and more effort into this, maybe we can have organism or bacterial specific uh, markers to go after rather than just straightforward glucose.
We put this 2023 statement together to just mark where we are clinically in the management, prevention, and diagnosis of CID infection. Going forward, we really need help. You know, I mentioned the PADIT and RAPID trials. Those are randomized trials. Those are really the only trials we have, randomized trials in CID infection. And so, as we think about potential interventions, diagnostics, et cetera, we really need randomized trials to help us better define the optimal uh, management strategies.
Yeah, exactly. Are there some patients where device removal should happen sooner than later, or uh, uh, maybe it's happening too soon? I don't know. And we touched a little bit earlier about timing of reimplantation. So for those patients who do need a new device reimplanted, Um, one thing we touch on is that in some folks where they have cardiovascular, where they have infective endocarditis, delaying reimplantation for up to 2 weeks. And these patients may have to remain in the hospital or may have other interventions that can have the patient discharged earlier, but they may need to wear a wearable defibrillator or potentially a temporary permanent pacemaker being placed. And so there's a lot, we do discuss that in the statement, but I think, as you correctly mentioned, of the randomized control trials that are out there, some of our best evidence has really only been done in prevention and
Mhm.
pretty much nothing in management, or sorry, in diagnosis and management. So, Dr. Bador, I completely agree. These are definitely key parts that we want to emphasize to our colleagues to focus on these areas of evidence gap and future considerations for the next iteration we can have advances in these diagnostic techniques as well as treatment modalities for our patients. I am Dr. Daniel D. Simone, and it's been an honor to discuss this with my colleague, Dr. Larry Bador. Thank you for listening to our statement on cardiovascular implantable electronic devices and their prevention, diagnosis, and management.